Good afternoon. My name is Dorothy Burridge, and I'm the Regional Education Coordinator with the Central East Stroke Network. On behalf of our network, I would like to welcome you to our webinar today, Applications in Post-Stroke Spasticity, presented by Dr. Hilary Clausen. And I'd also like to acknowledge that this program is being sponsored by Allergan Canada. So before I turn it over to the presenter, I just want to remind you that you can submit your questions by typing them into the questions section of your control panel. And also there is an evaluation form available in the handout section, as well as you will receive a link in a follow-up email. So we would encourage you to please complete an evaluation. It gives me pleasure today to introduce Dr. Hilary Clausen. She is a physiatrist who graduated from McMaster University. She has a practice in physical medicine, rehabilitation, and electrodiagnostics with a procedural and interventional-based outpatient practice out of Barrie. She also manages amputee and orthotics clinics and runs spasticity clinics in multiple long-term care facilities. She has a special interest in spasticity management, including chemodenervation, and is currently a part of a national post-stroke advisory board and expert faculty in education programs for post-stroke spasticity for pharmacists. Dr. Clausen is looking to support primary care specialists and allied healthcare providers in the community in their recognition and management of spasticity, as well as cervical dystonia, blepharospasm, hemifacial spasm, and chronic migraine. Outside of work, she enjoys playing all sports, especially volleyball, and spending time with her two children, husband, and puppy. So I'm happy to turn it over to you, Dr. Clausen.
Thanks, Dorothy. I'm truly honored to be invited to give this talk today. It happens to be on something that I'm very interested in, spasticity. I always have been. I think I've been interested in it because it really affects the patients that have spasticity, and it also affects their caregivers. And so the treatment of it has been incredibly gratifying and rewarding, and the patients are continually grateful for it. And I want to say that that is always in conjunction with teamwork from their allied healthcare therapists. And I'm so grateful for those of you who have experience treating patients with spasticity, because it's such a team effort for them to have benefit in treatment. So sincerest of thank yous for even coming to listen, but mostly to your shared care with these patients. I really appreciate it and am excited to learn with you guys. So today we're talking about post-stroke spasticity mainly. I will touch on other types of spasticity. With disclosures. Oh, there we go. My disclosures, I am a part of a national advisory board and receive an honorarium for both that as well as this talk through AbbVie and Allergan Canada. Our learning objectives for today, at the end of the presentation, we're hoping that you will know what spasticity is and how does it present specifically in the post-stroke patient. We want to know what are the consequences of spasticity, and so why it needs to be treated or when it needs to be treated. When should you intervene? Should it be early or late for the optimal prevention of secondary issues such as contractures, pressure sores, and pain complications? And what are the most important goals of treatment for these patients? What are important concepts with the primary care clinician, that is you guys, and what should you be made aware of when you're identifying spasticity, managing them, and referring to other specialists? So what is spasticity? Simply put, patients will call it muscle tightness or stiffness. And more nerd-like, we refer to it as a velocity-dependent increase in tonic stretch reflexes. So it's a velocity dependent increase in your muscle tone. There are other types of increased tone, but specifically spasticity is when you're moving the arm or leg, for example, as you increase the velocity, then is when you see the increased tone. So what happens in spasticity is you have an unopposed contraction of the muscles, and this leads to spastic dystonia. Then the patient can have abnormal limb posturing, they start to get soft tissue shortening, you have other biomechanical changes in the contracted muscles that we can actually see at a biochemical level, and this prevents the patient from muscle lengthening and perpetuates further tone and contracture. So you can see spasticity in any injury from the brain or spinal cord. So in today's talk, we're focusing after stroke, which is one of the most common adult spasticity presentations. In pediatrics, a majority of it is seen in cerebral palsy. You can see it in traumatic brain injury, multiple sclerosis, spinal cord injury, as well as acquired brain injury. The presentation of spasticity can be in a number of different ways. One of those being in which part of the body it presents itself. In stroke, we often see it being focal, meaning across one joint, such as this picture on the bottom left is a hitchhiker's toe. So it's spasticity or increased muscle tone in the extensor hallucis longus. And then you can also see it in multifocal, which is that top right picture, and that's across multiple joints, but still in one limb. And in spasticity, or in post-stroke, we even call two limbs, such as if your left side of the body, upper and lower limb is included, we would call that focal or multifocal. You can also have regional spasticity, such as the top left picture, where you see the adductors involved in both lower extremities. This one I see quite often in patients with multiple sclerosis, or in pediatrics, more in keeping with cerebral palsy. And then you have the generalized, which involves multiple limbs, more than two specifically, and often both upper and lower extremities, and sometimes your trunk as well. It can include your neck. And this is usually seen more so in more progressed cerebral palsy or multiple sclerosis. So some examples of focal spasticity that you guys may recognize. These are common, the more common patterns in terms of muscle tone. So the left one is adducted internally rotated shoulder. You start to see the patient adducting the shoulder with stiffness, pulling away from the body. It's difficult to pull their arm when you're trying to dress them or clean them, as well as internally rotating. And we actually see this pattern often in post-stroke, and actually contributes to post-stroke shoulder pain, and we'll talk a bit more about that. But this pattern of adduction, internal rotation of the shoulder, causes stiffness and painful passive range of motion, as well as issues with bathing hygiene. You can have skin breakdown, trouble with deodorant application, and upper body dressing. The flexed elbow on the right can often lead to skin breakdown or maceration at the intercubital fossa. So if it becomes too tight, you get flexion contracture. Patients will also, or caregivers for that matter, will also complain about difficulty with dressing, as they can't open up that arm to get a sleeve on, or a coat, for example. I start to see it more now as we're dressing in layers in the winter with my patients. So they also, if it's someone who has function of that arm and they want to reach, for example, to their plate or their cup to drink, or their phone, they have trouble as that tone gets tighter in their elbow flexors for reaching and grasping objects. And as you can imagine, it affects their day-to-day life and independence. More examples, clenched fist, pardon me, or thumb and palm. And the fingers are clasped into the palm. You have an inability to wash that palm, and it becomes quite odorous. This is actually a really common one that I see in the long-term care homes, and you can start to have their nails dig into their palms. You can get infections, obviously pain with it, and it can be quite difficult for their caregivers as well when they're trying to do nail clippings, clean in their arms, and it's not, there's no picture here, but you can also get, as your finger flexors get tight, your wrist flexors can start to flex more and can also cause symptoms of carpal tunnel syndrome, and you can get significant weakness as well. Patients with this type of spastic tone can also have trouble putting their hands in sleeves because they can't get through narrow openings, and it becomes an issue with dressing. You can also get a flexed knee, another common presentation, and the hamstrings become overactive and flex the knee. This can also extend the trunk. So some patients with significant tone at the knee flexors will actually find themselves being pushed into the back of their wheelchair because of the flexed hamstrings. And it can cause a lot of shearing force at the ischial tuberosities. You can get skin breakdown, pressure injury, as well as skin breakdown at the back of the knees. And some patients then have significant trouble even being able to sit independently in their wheelchair. Adducted thighs. This one is, again, usually seen more in more severe injuries or with both lower extremities involved in things like MS or spinal cord injury, brain injury, cerebral palsy. But adducted thighs can become quite an issue in terms of caregiving, as it's difficult to dress the patient, lots of difficulty with hygiene issues and skin breakdown as you get lots of moisture in the area and you can't clean. That moisture builds up, and it really can be quite an issue in terms of pressure injury. The equinus foot deformity. This is actually not a great picture, but most of you will know when we are looking at more common equinus foot, it's going to be plantar flexed, internally rotated, with tone in your plantar flexors as well as a posterior tibialis, and your toe flexors can also be pulling your foot into plantar flexion and internal rotation. This is common actually in post-stroke, and it causes difficulty with patients in terms of having independence with their gait. They have difficulty and pain wearing their shoes. They can have skin breakdown, not only from shoes, but if they're trying bracing, such as with an AFO, you can get skin breakdown on the medial edge of the foot when it's pulling in with your tib post. You can also have skin breakdown on the lateral edge of the foot as well. So again, more common patterns in post-stroke spasticity specifically are your most typical is going to be an adducted and internally rotated shoulder, flexed pronated elbow and forearm with a flexed wrist and clenched fist, sometimes thumb and palm, sometimes not. And that's your most stereotypical. You'll actually, sometimes if you're going to evaluate these patients, seeing them walk will really bring out this upper extremity pattern more prominently. And for some people, actually is aesthetically really bothersome for them. In the lower extremity, you can commonly get a striatal toe, and patients will tell you about this if they're getting wear or pain on the top of their toe from wearing in their shoe. Otherwise, you can also have curling of the toes, which can cause trouble with patients who are ambulatory. We talked about the equinovarus deformity, and which again, unlike that picture, is actually more commonly significantly plantar flexed. And you can also get an extension of the knee rather than a knee flexion. And becomes troublesome with gait, as they also have underlying weakness, which can catch their toe when they're walking. This is a video of hemiparetic gait, and it is a physiotherapist doing, but he points at some of the dynamic pattern that you may see. Let's see if I can do it.
The hemiplegic gait consists of flexion of the hip.
So as you can see there, you can see that he's having flexion of his hip. I'll start it again here. He flexes his hip and lurches his trunk to pull his foot in to circumduct it around. You can see that he has significant extension of his knee, and well, ideally he should have plantar flex, internally rotated foot. So he has trouble clearing that without having to lurch his body over and flexing the hip. In the upper extremity, you can see that internally rotated, adducted shoulder, pronated wrist flexion come out as they're walking as well. Okay. The prevalence of spasticity is quite prominent. So some studies state between 40 and 60% of patients with stroke will go on to have spasticity. An estimated 12 million people worldwide struggle with spasticity, whether that's from stroke or from other central nervous injuries. And in stroke, you may start to see, or the studies here have quoted 27% of post-stroke patients have signs of spasticity within 6 weeks of their stroke. It can become a chronic problem or once it is present, and it should be monitored with time, especially when you're seeing it in these early days. And then they may go on, up to 52% of post-stroke patients can develop contracture within the first 6 months, at least at one joint. And that's something generally that you want to monitor for, as depending on the joint involved, prevention of that contracture can be succeeded by early intervention. So lots of patients have spasticity, and due to different injuries, including stroke. So why does that spasticity matter, or why would we want to treat it? The impact and the burden of spasticity can be actually quite high, which I alluded to as into why I love treating spasticity. But patients can have troubles with contracture. These muscle tightness can significantly limit their active function as well as progression with rehabilitation in the early days in terms of achieving function, both in the upper and lower extremity. They complain of limitations in passive function. So this is usually with caregivers in terms of having difficulty with hygiene, positioning, skin breakdown. And they can start to have troubles with pain, whether that be from pressure injury or at the shoulder, for example. A lot of patients will really struggle with dependence on the caregiver because of tightness at different muscles. And they, in almost all studies across the board in terms of studying spasticity, you will see reduced quality of life. Poor self-image can be an issue, as well as an increased risk of falls. For caregivers, spasticity is significant in terms of increasing burden. It increases fatigue, emotional unwellness, disruption to their life. They may see, work absenteeism, loss in work productivity, reduced quality of life for the caregiver. and a caregiver disability can be related to directly to increased need for hygiene and dressing for the person that they are helping with. So we're gonna use Bob here as a case study or an example of a common presentation. So Bob is a 55-year-old male who's had a right MCA territory stroke. He is seen by the therapists on the floor as well as the nurses, noting to have complaint of problems at his left shoulder. They've seen that he's had tightness in his pecs and biceps at the shoulder, in his fingers and wrist flexors. He's starting to have shoulder pain, and his shoulder has been noted by the therapist to be subluxed anteriorly and caudally, and he's been traumatized by poor handling and positioning that he had in the acute care setting that can contribute to post-stroke shoulder pain. He complains of his problems as having trouble sleeping, as he can't find a comfortable position due to the shoulder pain in the positioning of his arm. He has trouble bathing now or getting dressed with considerable pain at that left shoulder. So the timing of the intervention for post-stroke shoulder pain is very crucial. And as you can imagine, in Bob's situation, treating his post-stroke shoulder pain, that one big part of it is the tightness and spasticity can make a big change in direction of how his management goes. Is he able to participate in rehabilitation? Is he able to learn how to dress himself? Can he be positioned properly in a wheelchair? Lots of things by treating early can make a big difference in the direction or projection that his treatment goes. So how would you evaluate spasticity initially? When we look at spasticity, it is incredibly individualized, which is another reason why I really like it, because every patient that presents to me with spasticity has significantly different goals, different muscles involved, how it affects both them and their caregivers, their day-to-day life. And so your treatment, as well as your evaluation, is very individualized. So how does that increased tone or that spasticity affect their function? Does it affect their gait? Are they ambulatory? Does it affect their positioning in a wheelchair? Are they getting skin breakdown? Are they having trouble dressing, whether that's lower extremity or upper extremity? Can they transfer? Are they finding that that tone in their leg is actually helping them transfer? Or is it hindering them? Are they tripping over things? Are they having, are the caregivers having trouble with catheterization because of adductor tone? Once you look at function, including passive function, then you're looking at risks of complications or presence of complications. And again, this is going to look like the main culprits are skin breakdown, pressure injuries, or contractures at different joints. Does the spasticity result in pain or discomfort? So whether that's like Bob with post-stroke shoulder pain, specifically at the joint involved, or is it from discomfort with wearing a brace, like rubbing of the inside of the foot with internal rotation of the tib post, pressing on either a brace or footwear? Are they getting pain at their ischium because of extensor tone or knee flexion tone pulling them in their wheelchair? Allergan or studies have come up with this risk classification system that's been distributed through Allergan that helps to understand where to go if you do see spasticity. So this is just a helpful tool in terms of referring and knowing when to refer or when to follow up. So using the risk classification system, an urgent referral would be recommended if you see a patient who has significant tone, significant pain, it's severe across 2 or more joints. Honestly, if it were across one joint and affecting their function, but it was severe and progressive, I would still want to see that patient sooner rather than later. They also recommend if they have severe loss of sensory motor function. So are they having severe decrease in surface sensation? That can be especially with people who are ambulatory or walking. Do they have impaired proprioception? Those would be reasons for them to be referred to a spasticity specialist sooner than later. And I know we have people across all parts of Central East Ontario, so probably your communities and your referral patterns are going to look very different in terms of who you need to refer to. But whether you have a specific spasticity clinic or you have a neurologist or a physiatrist that specializes in spasticity, these are the types of patients who would benefit from a referral right away rather than watching and waiting as they progress through rehabilitation. A routine referral, meaning they can be seen in a routine amount of time. For us in our community, we don't actually have a multidisciplinary team per se in terms of spasticity management. It ends up being all put together by referral. But if you do have a multidisciplinary team, this would be a patient who you've seen mildly increased muscle tone across one joint and involuntary muscle contractions in the affected limb, and including reduced sensitivity on the one side of the body or visual inattention or weakness of the limbs. Most often you're going to see a combination of weakness and muscle tone. And as that, if you see difficulties in their active range of motion, that's starting to affect their rehabilitation or their daily living, this would be someone who definitely needs to either start or continue with physiotherapy or occupational therapy and consider referral to a spasticity specialist on a routine basis if there's progression of their symptoms. Then you're going to have patients who've had a stroke and who you want to monitor periodically. And ideally, this would be seen through a primary care physician, whether that's a family doctor or a neurologist if they're in the post-stroke clinic. But sometimes it's going to be you guys who see them on a regular basis, depending on what part of Ontario you are in and how post-stroke care is taken care of. But these patients, if they've had a stroke, this is something that's on your post-stroke monitoring that you want to watch out for, is development of spasticity. So this can actually look like persistent loss of dexterity, as well as increased tone with time or contracture formation. Sometimes it's as subtle as just developing areas of recurrent skin breakdown that can point towards persistent spasticity that may need to be treated. So this slide covers a lot, so we'll hang out here for a minute. Spasticity clinic evaluation process. So this is more so something that once I have a patient referred to me, what do I then do? So if you're wondering, I mean, they would be referred to me with a question or concern of spasticity development or muscle tightness. And the first thing I'm going to do on my examination is differentiate it from other types of increased tone. So for example, rigidity is a non-selective increased muscle tone. It is not velocity dependent, meaning it's as tight as it is when I'm moving slowly versus if I'm trying to move it fast. There's no difference in the increased tone. Rigidity is seen most commonly in things like Parkinson's disease. Paratonia is an increase in muscle tone that's proportional to the force applied, not necessarily velocity. It can be, it's a little less consistent and more so you can overcome it at times, or the patient can that tone can go away if less force is applied to it. Paratonia is most commonly seen in things like dementia. You can have both spasticity and paratonia, for example, and that can become quite tricky. But often by treating the spasticity, you'll see some improvement in function despite the underlying paratonia. So identifying potential triggers. So this is something I spend a lot of time with patients and their caregivers in terms of when I am seeing them over long periods of time and their spasticity waxes and wanes. We want to identify triggers that actually can make your spasticity worse. So those things most commonly are things like urinary tract infections, kinks in the catheter, skin breakdown, pressure injuries, constipation, pain, any pain anywhere. So that includes ingrown toenails, tight-fitting clothing, infections. The list is very long, but if you're seeing a patient whose spasticity kind of has gotten worse over time and you're not entirely sure why, you want to look at the list of triggers and go through that with them. And this can take re-education with them and their family members. You want to remove those noxious stimuli first before treatment. Then we measure spasticity. So that often, for me, is going to be, I often use the modified Ashworth scale. There are a slew of different scales. One's not better than the other. It's usually for to work through whether you're seeing success in terms of treatment of spasticity, but honestly the most bang for your buck is going to be talking with them, and it hasn't made a difference in their function. But in terms of your own documentation and knowing if it makes a difference, I personally use modified Ashworth score, but again, there are lots of different numerical scales that can be used for assessment. And then assess their impact on their function. So with my patients, I'm very clear about that treatment of spasticity is goal-oriented. So if you're coming to me and you're like, hey, I have increased muscle tone, how is that affecting you? And what are your goals? So some patients I have really want to be able to move these 3 fingers so that they can grasp a pen, and I can treat those 3 fingers specifically. I have some patients who have significant adductor tone and want gender reassignment surgery, so we're treating their adductor tone so they can have surgery. Every person's goals are very different, and to have that discussion about attainable goals is incredibly important in spasticity management. So when do we treat the patient? So if muscle overactivity interferes with function, we've talked about this lots, passive function, or if they're symptomatic. You want to treat them if they're, in some patients, it's a discussion of we are going to keep you from progression. So we want to avoid contractures, skin maceration, decubitus ulcers. So it's preventing or maintaining where they are now in hopes of preventing progression. These are often patients with adductor tone of their legs or clenched fists. We may not fix the contracture, but we can prevent it from worsening. So again, goal-oriented treatment. What are the aims of treatment? We want relief, giving them relief of symptoms. We want functional improvement, decreased caregiver burden, avoiding progression of impairment, aesthetic or postural appearance. Some patients are really bothered by that elbow flexion when they're walking. Enhance the impact of conventional rehabilitation. So when I'm lucky enough to work with other rehabilitation therapists, such as yourselves, and working side by side, I get to hear of, okay, this person's making great improvements in their hand function here, but I'm really noticing their pronator tone is really limiting us. So then I get to treat that pronator tone specifically for their rehabilitation progression. So relief of symptoms. Again, we'll breeze through these because we talked about most of them in detail, but the relief of symptoms can include things like pain, such as post-stroke shoulder pain, muscle spasm frequency. So in spasticity, not only can you have increased tone, that's what the most common type of spasticity you'll see in post-stroke, but in spinal cord injury, for example, spasticity often looks like muscle spasm. So you may hear a patient talk about at night or in the morning, I have these painful jerky movements. That's also spasticity, that's spasm. And often is worse with things like transferring, can wake them at night, and that is a form of spasticity that can be incredibly beneficial to treat as well. Involuntary movements, knocking over cups has been one a patient had an issue with. Functional improvement, so they want the improved ability to do the following things. They want improved mobility, so treating their lower extremity in terms of gait. Improved ability to transfer, improved dexterity in reaching, self-care, personal care, eating, drinking, sexual activity. These are all things that can give patients increased independence and significantly increase the quality of life. Decreased caregiver burden. This can be a big one. So helping the patient with ease of moving, handling, positioning by treating some of their increased tone. It can help with routine day-to-day care, such as dressing, hygiene, toileting. Avoiding progression of impairment. So we want to treat spasticity in hopes of prevention of contractures and deformity. This can help with splinting and bracing, as well as particularly if they're going to be having prolonged use, such as an AFO. We want to avoid or optimize posture and seating, so especially in patients who are in the wheelchair a lot of the time or lying in bed, being able to have positions that reduce shearing forces, as well as comfort and improve the tissue viability. Whether if they're significantly increased in tone, they can have skin breakdown or soft tissue breakdown in certain areas. Aesthetic and postural appearance. This one's probably one of the least indications I see, but it does come up, and particularly I have a couple of patients who really struggle with that elbow flexion as they're walking. It will really increase as they're walking, and they feel much more comfortable when I'm able to treat that elbow flexion tone, and they're able to walk with their arm down and get a bit more of an arm swing and look more normal when they're walking. They feel much more comfortable. A lot of patients, though, do talk about improved fit or choice of clothing, especially again as we start putting on jackets and being able to fit their arms through narrow jacket openings, or keeps catching on my sleeve. That one's really common. Enhancement of conventional rehabilitation. So we want to optimize the effectiveness of therapies. Again, this is a focus where treating early has been shown to make a big difference in the studies. And we want to reduce the use of systemic medication to treat spasticity if it's focal. There are rules for generalized antispasmodic medications if they have generalized spasticity. But treating your increased tone of your elbow flexors by giving a medication may not be the best treatment in terms of side effects and progression with rehabilitation. It can also help inform potential surgical treatment. So in patients who are considering surgical management of that increased tone or across a joint, by treating the spasticity across that joint and seeing how they respond, you can get prognostication for surgical treatment, whether or not it's needed, whether or not they benefit it. Sometimes by treating that spasticity at a joint, you may actually find that surgery may have caused problems by treating that joint by with underlying weakness. So back to Bob. What are the goals of therapy for Bob? When we talked about Bob, he had his complaints were pain. He had pain with passive range of motion, which was with dressing, with positioning at night. It was waking him from sleep, trouble with hygiene, and transfers because of it. So he has lots of focus goals. So algorithm for spasticity management. Again, this looks very different in terms of referral patterns in every community, but referring to you as spasticity clinic or practitioner for new onset of spasticity, worsening spasticity without those identified triggers, new neurological signs, that might be best to a neurologist. Failure to tolerate or respond any oral antispasmodic medications, if their spasticity affects their posture, mobility, and care, and if it's associated with significant pain or discomfort. So then the patient agrees to treatment and you discuss the specific goals and aims with the patient and their caregiver. And again, it's talking about those specific goals and realistic expectations is key in spasticity treatment. So ideally, this is going to be multidisciplinary, involving spasticity specialists, family physicians, physiotherapists, occupational therapists, orthotists, nurses, wheelchair specialists. Genuinely, it involves all of those people. And when we're able to work together, patients feel the benefits of that significantly. So what are some non-drug interventions? There are tons of things that have been tried, and honestly, the evidence is kind of all over the place in terms of non-pharmacological interventions. Stretching and splinting is kind of mainstay of treatment, as you probably all well know at this point. A big part of that I find is, though I talk to patients about that, having a therapist who works with them, whether that's a PSW, an RPN, an RN, a physiotherapist, an occupational therapist, having someone that can educate both the patient and the caregivers or the family members in terms of regular stretching and range of motion exercises is incredibly beneficial, as well as just postural positioning in their chair or regular movements to avoid pressure injury, lots of education. And exercise, low impact exercise, getting into patients who do regular exercise like recumbent biking, arm ergometry. There's so many benefits to that, including with spasticity management. Oral antispasticity drugs. These are often used in generalized spasticity or those patients who are not having enough treatment with focal focus. So the first line often in post-stroke, specifically spasticity, is baclofen. Tends to be the most well tolerated, and you can adjust dosing quite well. Second line, often tizanidine or dantrolene, sometimes gabapentin. Cannabinoids, really the only evidence for that is in multiple sclerosis, and that's moderate evidence. So, and those would usually be done through family docs or a spasticity specialist like myself for neurology. The downfall of antispasmodic drugs almost across the board, the biggest side effect is sedation, which is not helpful in most patients. They can't tolerate it for their quality of life because most of them are going to have fatigue already. So other medications or other drugs for spasticity. There's botulinum toxin. There are 3 different types of that, and that is used for focal or multifocal. And this requires regular assessments by the person doing the injections and repeat injections on average around 12 weeks for most patients. Intrathecal baclofen is an option usually for bilateral lower extremity spasticity and significant one that's failed all the other treatment, and we don't do that here. It's down in the city if required, and requires regular monitoring and pump refills. And then there's chemical neurolysis, which is use of phenol or alcohol to basically lyse the nerves that supply those tight muscles and is used in severe spasticity of legs and also in bowel and bladder impairment.
Hillary, hi,
Yeah.
it's Natalie. We're at 12:45, just to
Okay.
let everyone know.
I'm going to skip this one because we kind of covered. Thank you, Megali.
Thank you.
So we're treating Bob. So we've seen Bob. The team approach is to educate Bob on what spasticity is, how it's affecting his post-stroke shoulder pain, and how to manage that. So we're going to show him how to actively and assisted use self-management of range of motion exercises. He's going to have passive manual therapy techniques when able, and he would be a great candidate for Botox injections. And for him, that's going to be the shoulder adductor muscles as well as those internal rotators and the elbow flexors. So I'm not actually going to talk about benefits of rehabilitation because you are the benefits of rehabilitation and you see that on a day-to-day basis, what that is, and you apply that. The Canadian best practice stroke guidelines suggest that for upper limb spasticity, that there is evidence for for regular range of motion exercises, as well as antispasmodic positioning in the earlier days, as well as stretching. There is no evidence for routine use of splints. However, in some patients, on an individualized basis, it can be quite helpful in terms of prevention of contraction. Chemodenervation, which is botulinum toxin, can be used to increase range of motion and decrease pain for patients with upper limb spasticity. The evidence for lower limb spasticity is actually quite similar in post-stroke patients. Again, the spasticity and contractures can be managed with antispastic positioning, range of motion exercises, and stretching. And these should all be done both early and late, though there's more evidence for everything in the late times, but evidence is changing to recommend things earlier. Chemodenervation or botulinum toxin injections, again, can help increase range of motion and improve pain and quality of life, but should be done by a experienced practitioner. Oral medications, again, done for a more generalized. Oh, we don't have time, but this would be my favorite part. So talking about botulinum toxin and how it works, in a nutshell, it works where the nerve speaks to the muscle at the synapse, and it prevents the release of acetylcholine, which is the chemical that grows across that synapse, and thus weakens the muscle from regular contraction. And that is the botulinum toxin works specifically at that synapse, so that's why injection of specific muscles can help loosen the exact muscles that we want to address. Within Botox injections, most patients, I use the 3 rules, so they start to see it take effect around day 3. Its prime is around 3 weeks. It's more like 4 to 6 weeks and lasts for about 3 months. So patients tend to remember that. I get to have a long-lasting relationship with them because it's reversible. I get to see them every 3 months. Is that 5:50 or is that 11:50, Megali?
It is, yes. So, I mean, if you have, a couple more slides to share, and then certainly Dorothy can monitor the chat.
Awesome.
Even if we have 7 minutes for chat, should be good.
That's
And
good.
just a reminder for people to put questions in the, start typing your questions in the question box. That would be great. Thanks.
So in terms of the safety of Botox injection specifically, it has a well-studied side effect profile in the lower extremity. In less than 2% of patients, there have been documented falls, pain in the extremity with the injections, joint pain, back pain, muscle pain, upper respiratory infection, injection of site pain. In my practice, outside of pain at the site of injection or bruising, I haven't seen any significant lower limb side effects. In the upper limb, in 1 to 10% of patients, they note hypertonia, bruising, undesired weakness, extremity pain, injection site pain, fever, flu-like illness. And in one patient, I have had weakness that the underlying weakness that was exposed that they did not like, and that was reversible. Outside of that, bruising at the site of injection, and no other side effects in my practice. However, these are noted in many studies from patients. Overall, it's very well tolerated. So who are candidates for Botox? Patients who have focal spasticity, dynamic spastic component is that velocity dependent or gets worse with walking, such as toe curling, striatal toe, elbow flexion, that dynamic spastic component, or spasms, nighttime spasms that are waking them from sleep. They need clear goals for treatment, and I can't hammer that home enough. But if they need functional gains, pain reduction, decreased burden of care, improved cosmesis, and it's not a generalized medications or haven't tolerated generalized medications for generalized spasticity. That's your oral agents. Again, the biggest side effect you can talk to patients about for oral spasmodics. They can work very well in some cases, but we often go very low and very slow because of decreased tolerance with sedation, dizziness, weakness. So for Bob, this is just out of interest, but in terms of when we decide what to do with injection pattern, for Bob, we'd be looking at doing the pecs and probably teres major in terms of a shoulder adduction, internal rotation. Though they talked about doing biceps in his case, but that doing the biceps really depends on whether they have supination or pronation tone, because you don't want to take away supination if they already have a pronation tone. So sometimes avoiding biceps at elbow flexion is important, and focus on brachialis or brachioradialis. But that's often where I need help from or feedback from physiotherapists or therapists working with them in terms of knowing exactly how they're responding in between treatments and how their therapy is going. So how'd Bob's treatment go? Well, he had injection at the shoulder and at the elbow. He's seeing his physiotherapist with regular range of motion activities, and he's doing those on a daily basis. His sleep cycle has been restored. He's able to do self range of motion and position of his arm. He's doing hand positioning outside of a resting splint, and he's been able to tolerate the splinting. He's hoping to progress with physiotherapy with the adherence to exercises on a continued basis, and he has regular follow-up with physiatry. So to summarize, post-stroke spasticity is a common impairment. It can negatively impact patients and caregivers. Post-stroke focal spasticity can and should be managed, ideally early, to prevent secondary effects such as contracture or skin breakdown. And it is important for healthcare providers to recognize spasticity ideally early and to refer to specialized physicians or be monitored by therapists or nurses as time goes on and be referred appropriately. Thank you guys so much again for joining me. Is there any questions in the chat?
There is. So thank you very much, Dr. Claassen. That was very, very interesting. One of our questions is if you could give us a sense of what the average cost to the patient is for treatment with injections.
I'm assuming that's referring to Botox injections.
Yes.
So coverage for post-stroke spasticity is actually covered after the age of 65. So it's covered by the government if they're 65.
Okay, thank you. Another question, and this would be specific to your practice, to your area, but are you looking for referrals while patients are still in hospital? Are you looking?
If you're seeing, so if they're acute, meaning within weeks from their stroke, and you're already seeing an increase in tone, it's affecting their rehabilitation, I would presume, I am happy to receive a referral. If it's not something that needs to be treated right away, I'm at least able to follow them with time to see if that's something that needs to be managed. I've had a couple of patients I've been lucky enough to get those referrals early and be able to treat things like their upper extremity, and it's made a huge difference in terms of their function, and also in someone who has been able, that early treatment has been able to keep them walking independently. So yeah, early referral, if they don't need treatment right away, it's something that I can monitor with them.
Okay, thank you. So just while we're waiting to see if there's any last questions, I will thank you again very much for taking the time to present for us today. And there are comments in the chat box as well, also thanking you for your time. I'd also like to thank Allergan again for your sponsorship of this, this talk, and very important talk. I will let you know that the webinar has been recorded and it will be available on the Central East Stroke Network website, hopefully within 2 to 3 days. And you will also receive a follow-up email that's going to include some information on the adult spasticity management clinics and specialists across the province, recognizing that we've got a number from across the Central East Stroke Network joining us today. And just again, a reminder to please fill out the evaluation. It's can be found in the handout section, and you will also get a follow-up email with a link for the evaluation. And we have been asked if there is a chance of receiving a handout. I have put that forward to Magali and to Allergan as a recognizing that is your slide deck. So we will follow up with you and let you know if you can receive a copy, or if not, if there are some other resources that can be shared that would support some of the information that's been put forward today.
Yes, thank you so much, Dorothy. I wrote to my manager. It does look like we will be able to, so you and I can discuss that, how I can get you a PDF version of the slide deck. And also the traffic light tool, should there be any of the attendees that would like that actual tool, which helps with the post-stroke spasticity classification. And just to add to Dr. Klassen's comment on coverage, again, fully covered by ODB for those patients that are over 65 that have suffered from stroke. And should those patients that be under 65, there's extremely good private insurance coverage, as this has been around for a very long time. So pretty much all submitted claims that go through a private insurer will cover the medication. And Allergan also has a copay program. So should there be a copay that the patient has to pay, Allergan also can cover that through various pharmacies. So there's strong coverage.
All right. So I think we are just coming up to 1 o'clock and there are no additional questions. So again, thank you to everyone for joining this webinar today, and wish you a great day. So thank you very much.
Thank you so much, Hillary. That was wonderful. Thank you.
Thank you.
Bye. Thanks, everyone.
Bye-bye.
Bye-bye.